and welcome to the Alabama Public Health Training Network. I'm Carolyn Byrne, Director of Governmental Affairs and Community Relations at the Alabama Department of Public Health. Thank you for joining us today for our program, Race and Ethnicity Data Collection. If you have a question about anything being discussed today, please call or email during our broadcast. You will see the email, phone number, and email address are on screen now and will appear again later in the program. Also, the handout, sign-in sheet, and evaluation are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will expire on November 1st, 2024 for nurses and social workers. If you are watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with your sign-in sheet and evaluation. If you are watching this program live, there is no social work test required. For social workers, if you're watching this program live, it qualifies for classroom hours. If you are watching on demand, it is considered non-classroom hours. And now let's meet our presenter today. Elizabeth Pugh is a public health educator here at Alabama Department of Public Health. Elizabeth, I know you have a lot of information to cover, so let's get started.
Hi everyone, and thank you for attending the Race and Ethnicity Data Collection Training. Today's session we will discuss how to collect race and ethnicity data and how it impacts health disparities and public health. Today's objectives are to understand the importance of collecting race and ethnicity data, decipher differences between key terms, identify the do's and don'ts of race and ethnicity data collection, how to properly collect racial and ethnic data, answer the questions regarding race and ethnicity, and how to use the data collected. So why is race and ethnicity data collection so important? First and foremost, it allows for the identification of disparities within certain racial and ethnic populations, which allows for potential development of strategies and even programs to reduce and possibly even eliminate the health disparity. This collection also contributes to interventions to improve the overall quality of care. And finally, race and ethnicity data collection provides us with the opportunity to evaluate and analyze the effectiveness of programs and intervention strategies to reduce any possible health disparities. Now let's take a look at a video exploring health disparities in minority populations from the Mayo Clinic, which will take us into a deeper dive of health disparities.
Almost in ways to exclude important segments of our population who need it most. And we need to look at how we create structures to meet people where they are. And the technology exists for us to do so. We need to change our mindset from we'll build it and they will come to a mindset where we provide reach people where they are, and that has to be very important.
When I learned about cardiology, I learned about the traditional risk factors, and they talked about, well, hypertension, and African Americans have more hypertension, and Native Americans have more diabetes, and that's the reason that they have higher risk of cardiovascular disease. But in fact, the prevalence of obesity, diabetes, or hypertension have roots in things that have nothing to do with biology or genetics. They have to do with redlining and living in neighborhoods that have poor access to safe exercise and physical activity and food safety. What mother chose to live in an unhealthy environment? She did not. There are generations and generations of reasons that her people and her family were not allowed to buy or rent in places that were safer. And so if we take several generations back and consider how hypertension, which we know that the risk of hypertension is increased among those who've experienced racism. There are studies that have been able to show that actually the experience of racism increases cardiovascular disease risk and risk factors.
I think of Mayo in Arizona's relationship with Phoenix Indian Medical Center, for example. So we send medical oncologists there to see cancer patients, particularly breast cancer patients, to help deliver care there. And some of those patients then wind up coming to us for care as well. And so I think there is a responsibility for those who have more resources to share those resources with the community. Really, participation in clinical trials really revolves around issues of equity and disparities. And so in order to make advances in bringing down some of the morbidity and mortality or suffering and death from diseases, we do need everyone to be represented in clinical trials. Clinical trials often allow patients access to cutting-edge therapies that can be life-changing and life-saving in many instances. And so to not have people participate in clinical trials in some ways lessens their ability to potentially get life-saving therapies.
If we look at the patients with triple-negative breast cancer, just that disease, and there's a differential in outcome between the whites and the Black population. So we think that most of the difference in outcome, it's probably not as important in terms of biology. We don't know yet. We're still looking at this. But it's a matter of, are they getting access to going to the clinics where treatment is available? Are they seeking care early enough? Because the earlier we can diagnose a cancer, the better the outcome. So look at that discrepancy. The reality of cancer, median 66 years. The reality in clinical trials is about 50 to 52 years. This is a gap that we have to continue to close, because we need to, after we complete the clinical trials, to understand how the older or the younger populations, and this is not talking about race at all, it's about ageism that exists as a discriminatory factor in this world. We need to understand safety and efficacy for the older population, because they are the ones who are mostly affected by this disorder.
One thing that is in national consciousness currently is the issue of algorithm bias, right? These AI things that we use in driving medical care. And it is more pervasive than you think, right? And there's a lot of bias either built into the instruments or to the algorithms that are developed in populations that don't include enough diversity, to the extent that when you now use it in everybody, including African American, Latinos, and other groups, it creates disadvantage, reinforces disadvantage, and could make it worse, make it less likely to get to healthcare soon enough.
In general, health disparities are described as the differences and/or gaps in quality of health and health care across racial, ethnic, and socioeconomic groups. Health disparities found in these groups can lead to a decreased quality of life, loss of economic opportunity, perceptions of injustice, premature death, etc. Health disparities are not only found within public health, but also within healthcare. Sources of racial and ethnic healthcare disparities include difference in geography, lack of access to adequate health coverage, communication difficulties between provider and patient, cultural barriers, provider stereotyping, and lack of access to a provider. These disparities found within healthcare systems contribute to the overall disparity in health status and affects many racial and ethnic minority populations. Some examples of health disparities are shown on this slide. According to the American Progress, Asian Americans are 40% more likely to be diagnosed with diabetes than non-Hispanic white Americans. African Americans have the highest mortality rate for all cancers combined compared with any other racial and ethnic group. Hispanic women are 40% more likely to have cervical cancer and 20% more likely to die from cervical cancer than non-Hispanic white women. These are just a few examples of known health disparities, and there are many more that aren't listed. Knowing one's race and ethnicity can help a provider catch many of these diseases in early stages or even prevent the disease from occurring through primary, secondary, and tertiary prevention. With incomplete data, we cannot address the issues that we know some races and ethnicities are more predisposed to than others. This image illustrates how public health data reporting works. First, a patient will seek out health care and services. Next, the entities such as hospitals, healthcare providers, emergency departments, urgent cares, laboratories, and other testing and vaccination sites will report the data to public health agencies such as the Alabama Department of Public Health. Next, the public health agency will transform the raw data into usable personal level information. Then the public health agency will transmit data and case notifications to the CDC if it is required. The COVID-19 pandemic emphasized that some racial and ethnic minority groups are disproportionately affected by diseases such as COVID-19. The lack of and even incomplete racial and ethnic data hinders public health practitioners from identifying and ultimately addressing COVID-19 health disparities and other health disparities that may exist in different population groups. The American Pharmacists Association and American Nurses Association said, race and ethnicity data provides critical information to clinicians, healthcare organizations, public health agencies, and policymakers, allowing them to equitably allocate resources across all communities, evaluate health outcomes, and improve quality of care and delivery of public health services. Here are some examples of data from the COVID-19 pandemic to illustrate the incomplete data on race and ethnicity. Of over 73 million cases of COVID, we only have race and ethnic data available for a little over 48 million cases. And of the 852,054 deaths, we only have complete race and ethnic data for close to 726,000. From April 2022 to May 18, 2022, COVID-19 cases reported to the Alabama Department of Public Health, there was only 15.4% of cases that had race and ethnic reported unknown, and 19.1% of cases had ethnicity reported as unknown. 6.3% of COVID deaths had unknown race reported, and along with 3.1% of the deaths were reported with unknown ethnicity. So why should healthcare providers collect race and ethnicity data? Many disparities in healthcare can be addressed if and when data on race and ethnicity are available. When racial and ethnic data is present, providers can ensure that all patients receive high-quality care, identify and eliminate any healthcare disparities, plan quality improvement initiatives, better understand the types of patients their facility serves, adequately provide proper services, and compare disease occurrence among racial and ethnic groups treated at their clinics. The Office of Management and Budget revised the standards for the classification of federal data on race and ethnicity in 1997 to promote uniformity and comparability for racial and ethnic data. We will discuss the minimum categories required on the next slide. Race is defined as a category of humankind that shares certain distinctive physical traits. These categories are white, Black or African American, American Indian or Alaska Native, Asian, and Native Hawaiian or other Pacific Islander. White is defined as a person having origins in any of the original peoples of Europe, the Middle East, or North Africa. Black or African American can be defined as a person having origins in any of the Black racial groups of Africa. American Indian or Alaska Native is defined as a person having origins in any of the original peoples in North and South America, including Central America, and who maintain tribal affiliations or community attachment. Asian is defined as a person having origins in many of the original peoples of the Far East, Southeast Asia, and the Indian subcontinent, including Cambodia, China, India, Japan, Korea, Malaysia, Pakistan, the Philippine Islands, Thailand, and Vietnam. Native Hawaiian or other Pacific Islander is defined as a person having origins in any of the original peoples of Hawaii, Guam, Samoa, and other Pacific Islands. Ethnicity is defined as the fact or state of belonging to a social group that has a common national or cultural tradition. And this is broken into two categories: non-Hispanic or non-Latino, and Hispanic or Latino. Hispanic or Latino is the identification that a person traces his or her origin or descent to Mexico, Puerto Rico, Cuba, Central and South America, and other Spanish cultures, regardless of their race. The collection and reporting of data on race, ethnicity, and primary language are legal and authorized under the Title VI of Civil Rights Act of 1964. Such information collected and reported systematically at the federal and state levels is critical for the success of efforts to achieve more equitable access to health care, improve quality of care, counter unlawful discrimination, decrease health disparities, and promote the delivery of culturally appropriate service to diverse populations. All patient data will be maintained according to the Health Insurance Portability and Accountability Act standards. The intent of this policy is to ensure quality reporting of collected information on the federal and state level. The Procedures and Guidelines policy states that the Alabama Department of Public Health requires that staff must instruct clients to voluntarily self-designate their race and ethnicity. The client's ethnicity data must be collected first before racial information is collected, and staff must inform clients that data collection is for reporting purposes only, and it will not affect their eligibility to receive benefits or services. For information on the Procedures and Guidance policy, refer to Policy 2019-008. When it comes to collecting race and ethnicity data, there are some major do's and don'ts. Don't guess the patient's race and ethnicity based upon their physical appearance. Don't force a patient to select an answer. However, do ask the patient to self-report. Do provide information to the patient, such as why the data is being collected and how the data will be protected. Do at minimum provide race and ethnicity categories based on the 1997 OBM standards. Do make multi-selecting possible, and do respect the patient's descriptions. This slide shows the patient response matrix. This is a great tool for training staff on how to answer patients' responses when it comes to collecting race and ethnicity. For example, if a patient says, "Can't you tell my race by looking at me?" an appropriate response would be, "We try not to assume a patient's racial or ethnic background based upon looking at them. We prefer our patients to let us know what they want to identify as." This slide is just a continuation of the patient response matrix. Shortly, we'll provide some medical staff and patient interaction scenarios so everyone can better understand how the patient response matrix works. If a patient says, "I do not identify as white, I identify as Latino, what do I mark?" the medical staff could respond with, "I cannot tell you how to answer this question. Answer however you most comfortable answering and however you best identify." If a patient says, "Why does my race and ethnicity matter? Will I get treated differently for answering these questions?" the medical staff could respond with, "These questions are designed to help us identify and address any avoidable differences in social services and health. We collect the same information from everyone. Your responses will not negatively impact you and your services or ability to receive any benefits. They can only help you." So once the data is received from a patient, how can it be used within the healthcare system? The data is ultimately used to reduce disparities across patient groups. From the data collected, we can discover the health disparity, diagnose the cause of the disparity, which allows for design and care transformation, define any goals for improvement and tracking measurements, and support improved care. The Colorado Trust stated that analyzing outcome data such as health indicators and disease rates with patients' race and ethnicity data and satisfaction data can help organizations better align services with patients' needs and preferences. Here you can find the references we used to create this presentation and find out more about health and disparities and race and ethnicity data collection.
Elizabeth, thank you so much for your presentation. And I do have a couple of questions that have come in the box. And so I'll start with, we often refer to ethnic data as cultural. So how is cultural and ethnic information different?
They're kind of similar in some ways because you trace the cultural backgrounds to where their ethnicity goes, such as when we said non-Hispanic and non-Latino versus Hispanic and Latino. But that's not the only cultural differences. For example, in Asia, they have different cultures than they do in the Hispanic known countries.
Okay, thank you. So we often see, and this came in the inbox also, that zip code determines health. And so when we look at this data and the fact that we're supposed to collect the ethnic data before the race data, why is that order significant? And then how does that help when we look at health being determined? I know in the video it talked about health being determined by where you live. So if you could address sort of those couple of points.
With the zip code, it's common for a lot of ethnicities to live in the same areas, so their zip code is going to be correlated to their ethnicity in many cases, not always. But collecting the ethnicity data first helps get a better idea of their cultural background versus their racial background. And then you know where they live, and their socioeconomic status can be based upon that zip code.
Okay, great. Thank you. I have two more questions. So sometimes people don't want to answer those questions, as you alluded to in the presentation. So as a social worker or nurse who's collecting information, why is it important for me not to assume ethnicity?
When you assume ethnicity and racial data, you're pre-labeling them, and that's not what they might not identify as. For example, someone might look Asian, but they might identify as white because they were raised in that way. So it's best to not assume, because their background could be different than what you expect.
This information all is data driven, so that when we went through COVID and we had a gap in data, particularly, during the pandemic, and people were trying to access care, how really does this data, and I know that some of the slides that you presented went over this, but why is data-driven solutions so important as a health educator? Can you address that? I mean, we're looking at really sort of focusing on collecting ethnic and racial data better than we have in the past. So why is this important to a health educator and epidemiologist when we look at these disease outbreaks or pandemics?
It goes back to some race and ethnicities have predisposed more likely to some diseases versus others. And with that data, you can understand if that ethnic or racial group is more predisposed to things such as COVID, being hospitalized, death rates, and stuff like that with it. So knowing the data could help determine that. And with the data, you could be like, this group needs more medication versus this group. Now, that might not always be the case because there is other underlying health conditions, but you know that you need to be on top of treating that patient.
Okay, thank you. And I just want to encourage people that have additional questions to go ahead and submit them. And we do have one more that just came in. So as a health educator and working with epidemiologists in public health, how would you address the fact that having this ethnic and racial data would have helped during COVID while the pandemic was at the highest level?
It would have helped tremendously in knowing which populations we need to vaccinate first, which ones need the medication first, which ones need more treatment. And it helped better with the hospitalizations, knowing, hey, this group might be hospitalized more versus this group. That way we could provide the best possible treatment to everyone.
And really sort of distribution of resources. We could have made better decisions on scarce resources at that
Correct.
time. Okay. Well, we just want to thank everybody for joining us today. This concludes our program for today. Please remember that you can refer back to the training and resources on demand anytime. And we just wish you a great day. And we hope that we can all do a better job on collecting this information so that we are better prepared. Hopefully we won't have pandemics in the future, but I'm afraid that's something that we can't avoid. So Elizabeth, we really appreciate you being here today and sharing this information with us. Thank you, everybody. Take care.